Hi, welcome back to Central Line. I'm your host, Dr. Katie Berlin, and I have two esteemed guests with me today. We are going to be talking about a theme that I really love, that I'm so glad that these two women approached me and said, this is something we'd really love to talk about. Are you interested? I'm absolutely super interested in this topic. And I think we don't give it enough attention in veterinary medicine. So I'm super excited we're having this conversation about collaborative care. Elizabeth Maxwell and Candice Manganaro, welcome to Central Line.
Thank you for having us, Katie.
Thanks for having us.
So both of you are doctors and you work together in some capacity, although not in the same building. And we'll get more into the relationship that the two of you have coming up. But before we get started, I just wanted to ask you both quickly to share a little bit about yourself, who you are, what you do, how you came to be here. Dr. Maxwell, do you want to start?
Sure. So I am from Miami, Florida originally. I went to Ross University for vet school. I did various internships, did my residency at University of Illinois, and then surgery residency at University of Illinois. And then I did a surgical oncology fellowship at University of Florida, after which I stayed on as a clinical assistant professor in surgical oncology. I'm also on the board of directors for the Collaborative Care Coalition, which has brought me here to you today.
I love that. And I had heard about the Collaborative Care Coalition, but didn't know a whole lot about it. And so we had a little intro conversation where we talked a little bit about it, and I've done some digging around, and I think it's super cool, but I also think it's also great to take this opportunity to talk about it because, I know from my own experiences in practice, the idea of collaboration between general practitioners and specialists and emergency veterinary care teams is sometimes a little bit fraught. And it's nice to think about us all as being on the same team. So anyway, more of that to come. Dr. Manganaro, would you please share a little bit about yourself?
Absolutely. So I'm Canadian, but grew up basically in Central Florida. So we moved when I was about 7. So Central Florida, went to University of Central Florida for my undergrad, and then went up to UF for vet school, and then came back to Central Florida. And I'm a general practitioner, dogs and cats, and just regular stuff.
Which regular stuff doesn't mean easy.
Yeah. No.
My background is in general practice too. And so I definitely understand it takes a special kind of patience to be in general practice. Okay. Well, I also wanted to ask you guys a personal question, just so we can get to know a little bit more about you. And so I asked you to choose a question to answer. And Dr. Maxwell, which question did you choose?
If I could put a Post-it on every veterinary professional's mirror to see first thing in the morning, what would it say?
Yes.
And I actually have this on my desktop computer at work that I see every morning. So that's what I thought of. And the quote is, a smooth sea never made a skilled sailor.
I love that one.
Yeah.
I love that one. Yeah, so true. And most vets don't have smooth seas, hardly ever. So we must be pretty good sailors.
Yeah, well, I have a Post-it note on my computer that says suck.
Mine says hit record. All right. Well, I do feel like we've learned a little bit about all of us. Simple and to the point. Okay. Well, good. And I love those answers. All right. So we're talking about collaborative care today, and I just wanted to start off by asking a little bit about the Collaborative Care Coalition. Can you just give us a rundown of just like what is that coalition and what is its purpose?
Oh boy, my lights went out. Is that okay?
Yeah, that's fine.
All right. So the Collaborative Care Coalition, we also refer to it as the CCC. It's a volunteer-based nonprofit organization that's comprised of primary care veterinarians, specialists, individuals from academia, and industry partners. And the mission of the CCC is essentially to achieve optimal healthcare for animals, advance veterinary profession, and evolve the relationship between primary care veterinarians and specialists.
I love that. And there's a lot encompassed in that mission. Like it's lofty goals, but also something that we can work towards in little bits in everything that we do, right? In our work as veterinary teams.
Yeah, exactly. And one of the main areas of focus for the CCC is in research. So veterinarians always are about evidence-based medicine, and so
Mm-hmm.
a lot of our focus is in research that shows that collaboration improves outcomes.
I love that. So you found that actually working together as a healthcare team, a unified healthcare team, improves patient care and outcomes overall.
Exactly.
Yeah, that's nice because there does always seem to be that group of people that think it's soft science, when you're talking about collaboration and communication and professional development in that way that isn't just hard clinical skills. And thus, as we talked about very often on this podcast, like the stuff that is considered softer sciences is sometimes the hardest stuff of all to get right. So that I like hearing that there's evidence behind that.
Yeah.
So, Dr. Manganaro, how are you involved in the CCC, if you are, and how do you know Dr. Maxwell?
So I'm mostly just, like I said, the GP. I'm out kind of in the realm of the kind of basic world and getting people up to Dr. Maxwell and some of the other referring veterinarians is kind of my role in that. And so when she suggested doing the podcast, she's like, we have emails going back to like 2014. I'm like, oh my gosh.
Wow.
So, yeah. So it's just one of those, one of those things that if you see enough, you're sending enough, and then you develop this relationship. And that's kind of my seat in it right now.
Yeah, that's great. And you're right. We do develop a relationship for better or for worse with the specialists that we refer to as general practitioners. And I can recall so many phone calls and interactions that I've had with specialists over the years, really good ones, ones where I felt like we really had a rapport, and ones that really weren't that way at all. And I always felt like kind of a thorn in their side. And I don't know how much of that was my own perception and how much of it was actually the way that they were approaching me. But I do feel like that's not an uncommon feeling among our colleagues.
Absolutely.
Yeah.
Yeah. And same. There's, especially now with the demand for everybody, right? It's hard to necessarily get into my favorite sometimes. And so there's more phone calls being done. And so different conversations and different kind of, relationships.
Yeah, absolutely. I remember there's an ophthalmologist in Pennsylvania that I used to refer to a lot when I lived there, and Dr. Brady Beal, and she was fantastic. And I remember she was examining a patient that I had sent her. I think it was a basset hound. And there were a lot of those sending the basset hounds to ophthalmology. But I think he had a heart murmur that she heard when she examined him that day. And she called me and said, I'm sending him back to you because this heart murmur isn't in his record and I think it's new. And she's like, I don't have any idea why he has a heart murmur. That is not my job. So I'm sending him back to you and you guys can finish the workup. And I thought that just made me feel so good because she was kind of like, I don't use these big heart words.
Not my spot.
Not my area. And she's like such a smart and capable specialist. And she also just doesn't hesitate to act like a human being on the phone with us. And the fact that I remember that, and that was, I think, in like 2011 or something, the fact that I remember that means that phone calls with specialists don't always go that way. And I was just wondering, Dr. Maxwell, how do you feel about that? Do you feel like there is an issue where specialists don't feel like they can develop that relationship with primary care vets, where they feel like they're overwhelmed or the primary care vets don't want that relationship from them? Like, what is the roadblock there for a lot of people? Do you know?
I think sometimes, very simply, it's time, right? So time to communicate. Communication is the biggest thing. And with everyone being overworked and burned out, to take the time and get on the phone to talk to someone about a case, sometimes it's just not there. And when, specialists are just sending records, from appointments to their primary vet. Like, there's no relationship building at that point.
Right.
So the relationship sort of has to be established at the beginning. For the first few cases, you're calling, you're kind of having that communication, and then maybe emails, and then the paperwork can kind of continue that more informal relationship. But I think that one of the biggest roadblocks right now is just having the time. And we have to be intentional about the time. We have to want to build those relationships, because if we don't put that as a priority, then it's never going to happen.
That's so true. And that's actually really closely parallels how we are with clients, right? Any veterinarian with clients, if you don't take the time to build those relationships, you're not going to reap the benefits of that relationship later on down the road. Eventually, it will save you time to have that kind of relationship with your clients. And, even like fear-free, low-stress handling, taking the time with your patients at the beginning probably will smooth things out very quickly down the road, because you won't have to build that trust every single visit. But I was thinking about, Dr. Manganaro, you said, we're all feeling overloaded right now. Everybody's at capacity or past capacity. How do you two think that collaborative care can actually help us deal with the overload that we're all facing?
So that was part of, what I was thinking about too, is that when I'm one of those that I want my clients to know every single option. In Dr. Maxwell's case, we're talking about oncological cases. And so I always try to get my owners to, even if there's lots of things, I'm not going to know all of the things. And I always encourage them to at least have a consult. Right now, a consult might be months out, or if that owner is like not going to do that, then I don't want to take up that slot for somebody else that could have got in. So now it's more, and I do more of, we were talking, Dr. Maxwell and I were talking about, she does email and text, and I'm like, I don't want to text you because I don't want to interrupt I don't want to take away that quiet time. I don't want to be like that person asking for advice off hours or whatever. So I will usually send an email, like, here's the case summary. Let me know when you guys can, if you want to email me back or you want to call me, whatever works. But that way I can get a little bit of, this is what we would potentially expect. This is the, rough idea of what we might be talking about. And then I can communicate that to the owners. And then we've already started that, where I've got in the notes, like, this is what we're going to do. This is what I quoted. The owners already know that part. And so I'm hopefully not taking up a space for something that's not going to move forward in that realm. And so I think that, and right now that's harder because of the time, but it's also more important because of the lack of time. So it's kind of both ways there on finding the time to communicate that between both me and the specialist and the owner, so that everybody's on the same page. And that's always my goal, is for everybody to know everything that's going on.
Yeah. And, I honestly don't mind when cases come for the conversation, even if they don't pursue surgery. I never have that feeling that, they took up a surgery slot,
Okay.
But honestly, what I find really helpful, just from the specialty standpoint, because we're booking out, 1 to 3 months in advance, it's often really helpful when the primary vet calls us and they say, hey, before I refer this case, are there any diagnostics that you want me to do that can help facilitate things on your end? And
medications too.
Yeah.
Like, we get do I start this and should I taper? Do you want me to leave it alone? What do you want me to do before he gets to you, so I don't mess up the opportunity to sample things?
Exactly. Because a lot of the way the hospital, it's just hospital logistics, right? Like, when they come in for an evaluation, we're not allowed to schedule ultrasounds and radiographs and CTs, on the same day. In private practice, that's a little bit more doable sometimes, but at least here, we sort of have to schedule them the next day or several days down. And so sometimes when they come with an ultrasound or they come with radiographs, that helps us get one step closer to treatment, if that's the route that they're going to take. So I find that to be really helpful when the vets call me and they say, what blood tests can I do? What do you need? And then I if they're able to do it, then that's really, really helpful on our end, but for the patient, because then they've already had the workup and they can come in for treatment,
And sometimes the answer is, we don't need that, or we're going to repeat that, and so I haven't spent extra time and money on something that's going to be repeated or not needed for that particular case.
I'm sure the clients appreciate that too, when they realize they don't have to do orthopedic radiographs twice, for instance.
Yeah, and that's really I want to say a hot topic, but that's a big thing, right? Is repeating diagnostics. And a lot of primary vets say, well, I'm not going to do this workup because they're just going to repeat it at the specialty hospital. But I don't feel like that's necessarily the case if we have the information that we need to proceed with treatment. And I think some of that breakdown in communication is what is needed, right? So, for example, you might take, for a cruciate ligament tear, you might take x-ray radiographs, of the knee, but for surgical planning, right, we need to take specific views. And so, I know some surgeons that actually go out to their primary care or their referring veterinarians and they say, this is how you do TPLO rads. This is the marker that you can put in it so that we can do the measurements at our practice, So having that relationship and saying, this is how we need it done so we don't have to repeat it is really helpful, because without that communication, you're going to take radiographs your way and then they're going to have to repeat it, and I don't think that we want to. We don't want to repeat diagnostics. We're not trying to just make more money on the patient. Like we just need to do what we need to do to treat them. And I think that's a misunderstanding, honestly, from both sides. And so sometimes the primary vet might be more willing just send the case without a workup because they're worried that we're going to repeat everything that's done. And I don't think that we would if there's that communication to say, this is what we've done, this is what we can do, what do you need,
Yeah, and I'd imagine that's different between different specialties too, So obviously you send a case to ophthalmology, they're going to do their 3 tests at the beginning, probably no matter what, but they should, because those things can change. Yeah. Your TPLO radiographs probably aren't going to change dramatically from, the time that it's diagnosed to the time it comes in for surgery. So that's really interesting. I've never heard anybody say that, like the clinic where I worked, we had a surgeon that came in and did TPLOs there, but we didn't have anybody from a referral hospital come in to teach our technicians how to do those things.
That would be
really cool.
I think
And probably, technicians at those hospitals could teach a lot too. They could probably teach certain bandaging techniques and stuff that, like I remember seeing a bunch of, I worked with a Boston Terrier rescue for a year or two, and they were always having their patellas fixed before they got adopted out, and the technicians who worked on them really learned how to bandage a leg really well, and that's a skill. It's a learned skill, and there's no reason that people in general practice can't learn how to do those things and take those radiographs that right way. But we also can't blame them for not knowing if they haven't been taught. And I think a lot of us feel a little bit embarrassed at not knowing how to do those things, and we're worried that we're going to be outed as like not knowing how if we do them, and then they go to their specialist and they don't meet a standard.
I remember bandaging something and I didn't have like some part that I needed to wrap it. I wrote in my notes this thing wasn't available, so I made do. Please don't make fun of me.
I think we suffer a lot from pride when it comes to these cases, and there was one time where I was seeing a neuro case. I think it was a vestibular case, and but it was like a 5-year-old dog, and so I wasn't sure if it was like it was definitely not your typical old dog vestibular case. And I, did what I could, and then referred it to neurologists, and luckily they decided to go, but the technicians had sent my records before I had a chance to write them. So it was like the vet assistant who was in the room with me, it was her notes that got sent to this neurologist. And she knew that I was going to fix them. So she wasn't even trying to write them like the specialist would need to read them. I was so embarrassed. I actually called the answering service that night and I was like, because I had worked with the neurologist in vet school. Like he was a resident when I was a student. And I was like, he's going to think I have gotten so stupid. So I was like, please tell Dr. Brewer, these are not the final notes. But we just worry so much about how we're going to be perceived. And I'm sure specialists also don't want to tell us that you don't know, or that you couldn't fix something, or like, how do we take the ego out of these conversations? It just seems like no matter whether we want to admit it or not, it's there.
Yeah. I was referring a fracture, and of course all the doctor words were just gone. I was like, the bottom part is like forward and up. I'm like, I'm so sorry. You'll see when I send you the X-rays.
Busted.
And the doctor was like, it's okay. I understand. I'm like, I just needed you to say it's okay because I apologize. I'll figure out the right words before I send the records. But like, this is bad stuff's happening. And like Dr. Maxwell said, just having that relationship of like, it's okay, take a breath. Tell me, it doesn't matter what words, just tell me kind of what's going on. And it makes it, if you have that conversation ahead of time, it makes it so much easier to have that relationship and to not be so, like you said, we're all humans.
Yeah.
We still know regular people words.
And it's very easy for us, right, to be self-conscious about the decisions we're making when someone else is going to be reviewing over it, whether it's primary or specialty. And, there has to be a mutual respect, that's kind of the bottom line. And it honestly always upsets me when I hear primary care vets saying that they felt, disrespected or mistreated by a specialist, made them feel stupid. It really, really upsets me. And, I think that from the specialty side, we have to appreciate that long-term relationship that the primary care vet has built with their clients and with their patients. And there's a lot of times that I've discussed treatment options, with patients that have been referred, and they tell me, thank you, but we're going to discuss it over with our primary vet first and then make a decision, and that always just shows me how strong their bond is with their primary vet and how they're going to rely on them for the decision-making for their pet's healthcare. So I'm always very impressed by that.
That's nice to know that impresses you and you're not just like, oh.
That's true.
I definitely, sometimes that bond is a little too tight, and it's like, well, I don't know what you should do. That's why I sent you there.
But I also consider that an opportunity to then have that conversation with the primary vet and say, this is what we discussed, right? Because if that doesn't happen, then the owner is relaying what you said to their vet, and then hopefully that communicated right. So if then we make that call and say, hey, this is what we discussed, you can then have that, they can then have that conversation well informed on both ends and help them make that decision.
This AHA podcast is brought to you by Care Credit. Care Credit understands that all veterinary teams are busier than ever. To help patients get the care they need, the Care Credit Health and Pet Care Credit Card allows clients to access a budget-friendly financing experience anytime, from anywhere on their own smart device. They can learn, see if they pre-qualify, apply, and even pay if approved, all on that smart device. With just a tap, they have a friendly, contactless way to pay over time for the services and treatments their pet needs, whether it be a general, referring, or specialty hospital, as long as they accept the Care Credit credit card. Do you have an example, for instance, of, I know you two have worked together before. Is there anything that you remember, any interactions in the past that you remember where you were really able to use that relationship in that way?
So the most recent one was a mastiff named Moose that had, and this is kind of a good example, like coming back to the general practitioner, is he was my patient, and then the owners moved away. And they moved back, and there was an exam to reestablish him with me. And they said, he's had ear infections, and he's got this mass kind of near his armpit that keeps getting bigger and smaller. I'm like, so about that, I don't like that. Let's take a sample of that. And it was a mast cell. It was a 4-centimeter mast cell in a not fantastic area, and a gigantic dog. And so we had the kind of discussion of, okay, I need to take really wide margins. This is how we're going to do. We have the option, you can do an ultrasound and x-rays first. And the owners were, okay, let's do surgery. And I said, depending on that, we might talk to oncology. And then he came in for surgery and he'd lost like 10 pounds. Like, whoa, wait, I don't feel comfortable. I think we should go have an ultrasound. So he went up and they called and said, so ultrasound doesn't work so good when they're 200 pounds. I'm like, oh no, I didn't even think about that. I didn't know. And I was like, oh, I feel like such an idiot, because the owner's like, of course, a human surgical nurse.
Of course. Yeah.
And I was like, I prepped her for ultrasound. Like, we've done the chest x-rays. We might talk about automatically sampling the spleen and the liver and those sorts of things. And then they're like, So for him, we'd have to do a CT. I'm like, oh no, I didn't tell her about that.
Oh man.
But that was one where they kind of like had the discussion and then kind of came back to me and said, yes, do those things first. And then the owner called me and said, hey, we've got the appointment to go back up and have the CT scan, but if they find something bad, we don't want to wake him up. How can we be in the room with him? Like, let me reach out to Dr. Maxwell and just let her know kind of the thought process there. And so then goes back up and sees Dr. Maxwell for the CT.
Yeah. And so I knew, how they were feeling about it. Right. And it was great because we were all sort of on the same page in terms of owners' expectations, and kind of talking them through the differences between the ultrasound and the CT. And it's not like we couldn't do the ultrasound, but I know mom wanted to be more thorough and make sure we weren't missing anything. And so, we did that CT and all was clear, great removes. And so, and so then Moose went back to Dr. Manganaro to follow up.
For surgery. Yeah. So then we were kind of clear and okay, we do need to cut it off. And mom says, okay, I want you guys to cut it off. I'm like, well, I'm having a baby next week. So so it ended up being, but that's another kind of collaborative part too, is that I have, I had a relief vet that had been kind of working for us. And I was like, hey, so I've got this 200-pound Mastiff that I need to take this huge thing off. Like, do you feel comfortable? And so then another kind of veterinarian got wrapped into it and she did a great job getting it and getting margins, and he's doing good and everything's healed up. So it was a funny little case where kind of everything kind of clicked together in different ways, and it got a lot of us involved in cases together. And it really feels nice, right? Like it feels like, hey, we did it. We fixed the thing and we made the boy better. And
that was a case too where we talked about what the surgical approach would be. Like, what would I do, right? So this is how I would measure the margin. This is the fascial layer that I would take, and this is all the surgical considerations that you would need to take for that surgery. And so, and I read it in your notes. I remember when you sent. Oh,
I was writing it.
When you sent your notes over, and I was going through it, I saw that you had wrote down what I recommended, which is good because that helped the next veterinarian who was going to actually do the surgery.
That's exactly. So I always write it in any way, but I knew that there was a potential for it not to be me, and there was, you said like, if you're in surgery and you need help, call me. I was like, oh, I can call you when I'm in surgery. Like, it made me feel so much better that I'm like, so you kind of like just cut and like just peel stuff out, right? So it made me feel so much better to be like, okay, I have a safety net. I have a safety line. It's okay. I'm allowed to call, right? Like, there's not that like, that made me feel so much better.
I love hearing stories like that. And, we are all so busy. Like, I know how busy specialists are. I know, specialists are booking out weeks to months, just like primary care. And I just think about all the times that a specialist has helped me by getting on the phone and talking to me when I know that time is really scarce. But I've always wondered how they felt about it. Like, are they just super nice? And then you have ones that won't at all get on the phone with you, and you're always sending messages.
Sometimes they're calling and it's like, it's 7:00 and I'm picking up the kids. I'm like, I'm sorry, you're calling me at 7:00. I have my kids in the car. Please ignore the,
But like, and I mean, as somebody, I had some pretty significant medical issues myself this year, and I had to see a lot of specialists. And no way in a million years was one of those specialists going to get on the phone with me if I didn't have an appointment. You know what I mean? And like, they definitely weren't going to consult with me to see if I needed to go see them. Like, that was not happening. And so I think I also have that mentality of like, I don't want to waste the specialist's time. Like, if the client should go, if I think the client should go, I guess they should go. I shouldn't ask the specialist to spend time with me on a case they may never see. How do you feel about that, Dr. Maxwell? Do you feel like it's sort of the duty of a specialist because veterinary medicine, the economics are different, the decisions are different?
Yeah, I wouldn't even consider it a duty, honestly. I think we all just naturally want to help people, and help our patients. And I never feel burdened by a call from a primary care vet asking about a case, whether it comes to me or not. I don't care about that. I want to help. And most of the surgeons, at least, and other specialists that I've talked to also have no problem getting on the phone and helping, any veterinarian that needs help. And, I don't think it happens as much here in academia, but when I worked in private practice, we got calls all the time from the referring veterinarian saying, "Hey, I'm in surgery. This looks weird. What should I do?" And that happened relatively frequently. And, I think it's great because it's in the best interest of the patient, right? Like, if you're in surgery and you feel stumped, you're probably going to feel bad calling the specialist. Like, you feel like you're in over your head, and maybe you're embarrassed, and you don't need to feel that way, and I think that it takes a brave person to get on the phone and say, "I need help." Right? I'm in surgery. I need help. And so I think because of that, I have a lot of respect for the vets that give me a call and say, "Please let me know what I need to do," and I honestly don't feel like most specialists would look at that as a burden or a problem, because they're trying to get ahead of making a mistake, essentially, or again, trying to just do what's in the best interest of the patient.
And we've all been in that situation, right? I mean, specialists, I'm sure in your training, you were in a situation where you're like, I don't know what to do now. And it's like a really, really bad feeling. And in training as an intern or a resident, hopefully you have somebody who is supposed to be available to you in those situations. I realize that could be in theory in some situations only, but you're not the end of the line. But as a primary care vet, often we do feel like we have to be good at everything, know how to deal with every situation. And that can be really, really scary, especially for newer grads, because everything is like the first time. And I'm sure it would be really, really comforting for a lot of more recent graduates to know that if they don't have their own boss available to help them, that they might be able to call a specialist and say, "Look, I'm stumped. I don't know what to do next."
And that's something I tell all my students. I tell them, when you're out in practice, if you hit a wall or you're having issues with a case, just call a specialist. Call one that's local. Call me. Call university. Call whoever might know a little more than you. That's okay, and it's okay.
Yeah. They should make those phones on the wall in surgeries. They should make those red. Like, get on the red phone. Yeah. Just like have everyone on speed dial in there. It's like the bat phone.
So the CCC did a study where they were looking at perceptions of the relationships between primary care vets and specialists. So they surveyed 242 primary care veterinarians, and they found that 55% felt that they were treated with mutual respect, but there was 22% that felt that the specialist looked down on them for their treatment decisions or for not referring sooner. So I feel like from that perception, we can do a lot better on our end to build that relationship, because it's been proven that knowing one another on a personal level will improve the quality of collaboration. And so, I always, we always talk about, things that we can do, such as like those lunch and learns or roundtable discussions, continuing education seminars. Those are all really good opportunities for the specialty hospitals to interact with their referring population or their veterinarians around the area to start building those personal relationships. And that allows you to get on that red phone, and make that call or text someone when you need help with something. And so I definitely think there's a lot of areas of growth for practices to kind of make steps toward collaborating better.
Do you see a role for telehealth in collaborative care? And if so, what does that look like to you?
Yeah, absolutely. I don't think that collaboration is just limited to, phone calls and emails. I think, having radiology review radiographs or imaging is part of that. You're consulting with a specialist or collaborating. And I know some of these, places where you send blood work to, they have specialists working for them that you can call and ask for advice. And I think all of that is included in, collaborating, between everyone's area of expertise. And so in terms of, I think we are a little bit limited based on state law, right? So, for example, in Florida, I cannot do telemedicine with a client I haven't seen before or within 12 months, essentially. And so if, really the only way we can do sort of telemedicine consulting is through the primary care vet, because they have that established relationship. And so I think that there is a role there, but there's probably going to be some limitations because of state laws. But certainly, when it comes to having the primary care vet consult with their specialists in the area about a case, that can definitely be considered teleconsulting,
Dr. Manganaro, do you think if you were I know you both have a personal relationship that's been sort of nurtured through many cases over many years, and that is wonderful. If Dr. Maxwell started charging for those consults. So we like to talk about our perception of value, and we need to get paid for our expertise. And we're talking about calling specialists with cases they may never see, with patients they may never lay hands on, and asking their opinion and taking that time. So, taking that a step further and saying, well, maybe they should be charging for that type of consult, which is sort of for us, a teletriage, where we're not giving direct patient advice, but we're consulting on the case. Do you think your clients would resent having to pay a fee for that service?
And I don't, and that's part of that, that feeling kind of guilty for calling and asking and knowing that they might be calling back at 7:00. It's well, maybe should they be charging? Because that's part of what this whole move, everybody trying to make sure that we're being paid for our time or setting the boundaries. And I don't want to blur those boundaries and those sorts of things. And I do think there's a oncologist that just does telehealth right now that I thought might be, and that in between that could do the consulting. And then if the owner elects to do treatment, she then communicates either what the primary care could do or gets them to a local oncologist. And I thought that was kind of an interesting little niche to be in. And I think if I say to my clients, and we always have that baseline, here are all the options. If, a referral is possible, this is what I would recommend. If I probably think that we could say, hey, if I can set up a consult and get you a little bit more detail and it would be X amount, I do think that there's a fair number that would say, okay, and let's do that. It's in between. We're not doing the full thing, but at least give us a better idea of our options. I'm also in a big retirement community. And so all our specialists, so Dr. Maxwell is about an hour and 15 minutes from us. And that doesn't seem like much, but for retirees, if they can't get there on their golf cart, sometimes they're not going. And so I do think that that may be a service that can be kind of charged for. I'm not quite. It'd be interesting. I do think that probably is a feasible thing. I don't know how it would fold in, but I do think, at least in the right clientele, that is something that could be monetized or compensated for the time.
Yeah, it's an interesting consideration. And there are some specialty groups out there that do strictly teleconsulting to the primary care veterinarian, and they charge for that. But their level of involvement in the case is much more significant than getting on the phone and having a conversation. They type up documents and they send information and they follow through on the entire case from beginning to end. So there's a lot larger level of involvement in those cases. And I like to think about the collaborative relationship as being the specialist as an extension of the primary care veterinarian. And so when you think about, at least for me, working in a specialty practice where I have primary care as well as all the other specialists, I value being able to go down the hallway and ask the internist a quick question about hypertension and
Yeah.
blood meds and blood pressure medications, or going over to dermatology and say, hey, what do you think about this? And if we started charging each other for that, we would probably lose that collaborative relationship that we have just within our own hospital. And so I think that, and we will charge if we put our hands on the patient and we're doing an official consultation where we type up paperwork and things like that. But I think for having a collaborative relationship where the primary care vet feels like the specialist is an extension of the care that they can provide, and that may be, like I said, limited to phone calls, emails, and just discussion about the case. I don't feel strongly about charging for that, but I get it. I understand, that value of charging for a time and taking those things into consideration. But I think you have to kind of find that fine line.
I agree. Like there's that, I don't want to take up too much time, but like you said, it does change the relationship from just, hey, quick question. Like this is what I'm seeing. And it would make it if it was always just that way, it would make it less likely for that relationship to develop, because then it becomes more of a not professional, but like, yes, a transactional relationship versus a relationship. Yeah.
That's true. And the idea of collaboration sort of transcends like the monetary value of these interactions, because like we know, I fully believe in telehealth, and I think we're going to continue to see it evolve and grow, but I still don't see myself ever charging for, like, the client calls and says, can I give this over-the-counter medication to my pet? And I'm like, no, I'm not going to charge for that. I will charge if they already gave it, and then we need to have a conversation about that.
We're talking about.
But the conversations, those little conversations, even if I'm on the phone directly with the client, that just build that trust and be like, okay, she's there for me. Like, that vet is there for me. That team is there for me when I need them, and not charging when it's a tick, and you just pull it off. Like, that kind of thing is so instrumental in building those relationships.
Yeah. I had a little arthritic dog that was on meloxicam for arthritis. And they came in because he, stomach upset and he's vomiting, he's not eating, and he looked terrible. I said, well, anything else? And they said, well, we've been alternating the meloxicam with infants ibuprofen to try and stretch out how long we got from the Medicam. I'm like, guys, this is just call me. We can figure it out. Sometimes there's donated medications. We can try and titrate it down. Like, just call me, because this was a dangerous decision, and, I wish that broke my heart that they felt that they couldn't ask. And I think part of it was they were, were just trying to stretch it as far as they could and didn't want to be told that, like, that's not okay. But that cost that little pup. And I really want that communication to be open. Like, just call me. Like, sometimes you're not going to get me necessarily, but I can certainly tell my receptionist, no, please don't do that. Well, I'll get you a more thorough answer a little bit later, but please don't give that.
Yeah. And it's to specialist benefits too. If we feel comfortable calling before we've attempted something or put something off for too long that should have been seen earlier by a specialist, for sure.
Yeah. And, whenever we have patients that are referred to us and they kind of are established, with us, even just with an evaluation, and they have no treatment with us, they're officially a patient of ours. If they have any concerns or questions, like, I'm more than happy to hop on the phone and talk to them about it. And that would never happen in human medicine. I feel like if you had a question after your first appointment, you're going to have to schedule something else just to talk to them again, And so I think that adds to the collaborative efforts, because the client is included in collaboration. It's not just the primary care vet and the specialist, but the client's included in that as well. And so having them be comfortable to hop on the phone with either the primary care vet or the specialist with help or questions that they have about their pet, I think is really important.
And a lot of times those follow-ups will come back to us. Like I said, if in my clientele, driving an hour and a half is a lot. So a lot of times they'll be coming back to me for a suture removal or, recheck chemistry, and being comfortable and sending that back up and saying, this is what I think, this is what I told the owner, tell me if I'm wrong. And then sometimes I'll get a note back saying, I disagreed. I called the owner and changed this, or they call me and say, and that again, like feeling like we're all a team. And I think that's everything that we want to do, is be a team to help that patient and that family.
Yeah, absolutely. And it is encouraging to see how the two of you have that kind of relationship and how you don't take it for granted. It's obvious that you appreciate being able to talk to each other in that way, but also there's no reason why we can't be like this throughout the entire profession. Like, we're all here for the same reason. And it's a really small profession as professions go.
And that's what we've been talking about, that a lot at work, as I have been maternity leave, and I'm trying to find people to cover it. It's, pulling from the vet moms group and like, can anybody, and kind of piecing it together. But it's like, even the clinic next door calling and saying, hey, we maybe need some saline. Can we borrow something? And then we just kind of like go back and forth. Like, I feel like we have to move away from being competitors, and we're all in it together. Like, if we can't see something or we need something, it's much nicer to be able to call the clinic next door, the specialist down the street, and say, hey, this is what I think, or this is what I can do. What are my alternatives? And it takes one level of that burden off, I think, if everybody's just be nice.
Yeah. I was going to ask you, one of the questions that I had sent you ahead of time says, what does truly patient-centered collaboration look like? And while you were talking about that, though, it occurred to me that we're not just talking about patient-centered collaboration. We're talking about collaboration that's better for the team. It's more mentally, appealing to and emotionally healthy to have these kind of relationships rather than have it be an us against them mentality, whether it's with pet owners or with specialists versus GP or the local ER. Like, that doesn't get us anywhere.
Yeah.
So I'm going to ask that to both of you now. Like, what do you see as truly collaborative care? So say you have a patient whose owners are reluctant about going to the specialist. They'll go if they absolutely have to, but they're not really sure if they want to or if it's worth it. What does that interaction look like to you?
So for me, those are the guys where, and I am one that, like, I will spend the time in the room. I will have that long phone call, and preferably not then calling the husband and having the same conversation. Right. But sometimes it's, hey, I'll call you back in a few minutes when you can both be on the phone. But, here's what I do lay out the gold standard ivory tower versus the minimum. But this is what a specialist would get us. And those are sometimes the cases where I tell the owners, this is what I think, but let me check really quick. And I'll call like Dr. Maxwell and say, hey, this is what I think. What else can I tell these guys? Or how important is this? What can I do from here? How does it change our likelihood of XYZ from happening if they can't go? And like I said, in my area, sometimes the answer is, I just can't. There's no way I can make it happen. Okay, well, then let's work together. And sometimes that means I'm calling and asking a specialist for advice on a case that they haven't seen, but I need help figuring out what other medication to add or where to go from here. And that being able to have those conversations and pick up the phone quickly and have that conversation and not be worried that it's a burden.
Mm-hmm. Yeah. And at your end, Dr. Maxwell.
Yeah, I just want to kind of piggyback off of what Dr. Manganaro said. One of the barriers to having a collaborative relationship over a particular patient is often finances, right? So the cost of going to a specialist. And so, when the CCC did their study and they looked at some of those barriers, they also surveyed pet owners. They found that cost was not actually the biggest barrier to going, but it was actually they didn't see the value in going. And so that kind of goes back to what you said about kind of communicating to the client what the value is in going to a specialist and how that might be beneficial to their pet. And some of the things that we found in all of these kind of surveys that we've done is that having the client understanding what that referral process looks like, or that if referral is indicated, of course, or if they're considering it, having all of the information before they come, and the accurate cost estimates tended to be one of the things that clients felt were really important from the specialty side of things. And so, and then when they get to the specialists, how do we make collaboration visible? I think that's really, really important. And so I always have all my conversations, and I end all the conversations with, I'm going to call your primary care vet and let them know what we discussed, and I always do try to make that effort when I can, when I have the time, right? But I always try to call and say, hey, I saw so-and-so today, and this is what we discussed. And every time I say that to a client, every time I tell them I'm going to call your primary care vet to let them know what we talked about, they're like, oh, really? That's great. And they get really excited. I think making the collaboration visible to the client is really important to make them feel that their patient is at the center of the care team, and so I think that having those communications, before they get to the specialist, at the specialist, and then, full circle, understanding that everybody is involved in the care of their pet is really important.
That says it so well. And I don't know if, many clients, I think, who have been the patient themselves can have a really, I think, deep sense of how much that means too, is like, even veterinarians who have been the patient themselves, when you're on the other side of the table, and you're thinking like, gosh, I was so scared when I was that specialist, or I really appreciated knowing that specialist talked to my doctor, my family doctor, and they had a conversation about me, like where I was important, and they came up with a plan together. That has happened to me, and I felt so taken care of. It should be normal. I don't think it's that normal in human medicine, but it made me feel just really like I was getting my experience at that the experience that I should have at that doctor's appointment. And that translates directly into what we do, and it can be so scary to be sitting there at a specialist's office and not know the person or the team. And you're like, I'm here because something's wrong. And with this pet that you're like, you can't explain to them like why they're here, and you're discussing all these procedures with some stranger. And that just like, I really just feel that in my heart, what you were talking about, where you just look at them and you say, we've got you, we're your team and we've got you. We're all in this together. That's just a great, great feeling. So
that's what I would like for just everyday veterinary medicine to be. Everybody's on each other's side.
Right? And I think it happens more often probably than we, like the interactions that go well, we often don't remember those, right? We remember the ones where it was like all went downhill or completely sideways, or we find out later that we thought it went fine and it really didn't. But the ones that go well, we never hear about again. And just kind of like, oh yeah, that was just a day. But that's like a little mini miracle every time that happens. And to that client and that patient, that was everything that day. And collaborative care to me means that all interactions should be like that, even with amongst each other.
And one of the cases that Dr. Maxwell and I were talking about is this little dog named Bentley that unfortunately has been up at UF through multiple services over the years. And he's one of the ones that goes back several years. But that owner, right, knows the process now. She knows, I'm going to get the phone call or the communication the next day. She's going to call me. And so he's been to oncology for scar revision, and then hyperparathyroidism. And then he went to dentistry, and then dentistry, one of the flaps dehits. And I called and I was like, hey, can I just repair this? They're like, yeah. I'm like, oh, that's easier. And Mom's like, thank God. I'm like, oh, okay, cool. So I've, fixed the other parts. So it feels like every little part of poor little Bentley has been touched by somebody else in different parts, but everybody's working together, right? So I think when he was up for, dentistry peaked in on him while he was there for his hyperparathyroidism through oncology, I think. So even that, everyone was working together to try and make sure that Bentley got taken care of.
Yeah, and he's been in and out over the last several years, 4+ years. And so it just shows you how the collaborative efforts can help for the overall, the patient healthcare throughout their lifetime, and so.
Yeah. This has been so great. I love hearing stories like that. I mean, poor Bentley, but also like, thank goodness for you guys and for Bentley's parents.
Mama. Yeah. The fact that I always feel like, oh, Kate, she goes, who, where now? Who do I need to? I'm like, I'm so sorry.
I know.
But she's so good and he's so good. And yeah.
Well, so if people like, I know when I first heard about the CCC, I thought, oh my gosh, this is really cool. How do I find out more about it? How do I get it? How do I get these conversations started in my area? Because I felt like people weren't talking about collaboration. People were like going to local CE and just like looking at each other, like side-eyeing each other, like across the table. And like, what is she going to ask, And I hate that. And I wanted to know more. And I didn't really pursue it because I didn't really know what to do next. Where can people like me go to find out more about the CCC and about how they can sort of develop that voice in their community?
So they can first check us out online at the collaborativecarecoalition.org. We are always looking for speaking opportunities. We're doing local conferences or national conferences, trying to get the word out and also, again, share our research showing that collaborative care improves patient outcomes. Anyone interested in collaborative care can reach out to any one of us on the board. They can find all of our contact information on the website, and we can kind of help them through. We've developed some guidelines and a white paper to help practices learn to collaborate better. And so we're happy to help anyone that wants to kind of take that next step.
That's awesome. And we'll put that contact information in the show notes.
We have been growing as an organization, getting the word out. And I think, the more and more people we have being aware of the process of collaboration and the benefits to collaborative care, then, it's going to be better for everyone involved. For sure.
Yeah. Well, thank you both so much for spending the time. I really appreciate having you both hop on to talk. Dr. Manganaro and her pillow fort. If you're not,
I have the nuggets.
If you're not watching, there's a pillow fort behind her, which is very cool. It's the first pillow fort we've ever had on Central Line. But I really appreciate your time and the efforts you're both putting into making these relationships the norm in vet med. I hope that one day they absolutely will be. So it's definitely a worthy mission.
Thank you for having us, Katie.
Yeah. Thank you.
Thank you both. And thank you all for listening. We'll catch you next time on Central Line. Hi, everyone. Katie here with Frankie, my little sidekick. If you're listening and not watching, he's a little chihuahua, and he's usually here with me on my lap, making little snuffly noises while we're recording. So he's my little podcasting buddy, and he'll probably get restless and jump down here. But I just wanted to tell you about this case that I was thinking about the other day. You know how we all have that case that pops into our mind sometimes? And mine is this little white dog that came in. I was probably 1 or 2 years out of school, and she came in on a Saturday. She was having trouble urinating, and of course she was one of those little white dogs, like a Bichon or something, where you look at them sideways and they get bladder stones. And sure enough, she had a bladder full of these spiky looking, probably calcium oxalate stones on her radiographs. And she basically couldn't pee at all. And her family was this dad and his 2 kids, and they paid in cash. They asked how much everything was. They seemed really worried about her, but also really worried about money. But they wanted to go to the ER. It was Saturday afternoon, and I didn't have the team to do the surgery, so she ended up going to the ER with them. And I was honestly surprised that they wanted to go. I had given them a ballpark for how much things would cost, and I would have thought that would have been financially out of the question for them, or that they wouldn't even have wanted to try. And I would have banked on her being euthanized ultimately, which is a shame. Because while I was writing up charts that afternoon, I got a call from the ER doctor who said that the family had applied for care credit and they'd been approved, and the dog was being prepped for surgery. And I think about that case a lot now, more than a decade later, because it taught me something about making assumptions, about reading people's intentions as well as their wallets, which we all can have a tendency to do. But that dog was probably saved that day by care credit, but also by the person who thought to offer the care credit. I had not even mentioned it at the appointment, maybe because they paid cash or maybe because they seemed so concerned about finances that it didn't even cross my mind that they'd want to try. And sometimes saving lives isn't just about being the person with the scalpel or the person running the anesthesia. It's about being the person who approaches a situation with compassion and gives somebody options that they didn't know they had, because that person saved that dog that day too. And, studies show, and personal experience, of course, show that moral distress, which is knowing that we can help a patient but being prevented in some way from doing so, is a really common cause of pretty consequential stress for veterinary professionals. And of course, one of the biggest determinants of whether we can help a patient is whether our clients have the financial means to do so that day. And I can think of dozens of times, probably hundreds of times, where that was a factor. I think maybe there was a scenario at least once a day for 12 years like that. And so I just wanted to thank our sponsor, Care Credit, for being there for that little dog and her family and all the dozens to hundreds of other patients who I know I was able to help because of them and because of the CSR teams who guided the clients through the application process and who made sure that they understood all of their options. I just really want to thank you for that. And also, I want to thank Care Credit for taking a chance on a brand new podcast where we had 0 listeners and 0 guests when they signed on. But now we are making these episodes with these amazing guests with so much to share. And I'm just so grateful that Care Credit is here for us at the beginning of this journey. So remember that your clients can learn and they can see if they pre-qualify and they can apply and they can pay all from their smartphone now, which was not the case 12 years ago. So I'm very grateful for that too. And that means that we can all do what we do best, which is go and use our skills to take care of little people like my Frankie here. So Care Credit, thank you. And thanks to all of you.